Welcome, everyone. I'm Jean Sachs, the CEO of Living Beyond Breast Cancer. We know when you're diagnosed with breast cancer, it is overwhelming. It's a complex disease, and there's so many things you have to do. What subtype are you? What stage are you? What test comes next? The list goes on and on. And we also know that the American healthcare system can be very challenging to navigate. If you're Black or you're brown or you have limited finances, lack of insurance, a language barrier, or anything else, it can seem unsurmountable. Today, we're going to hear from three amazing doctors, Dr. Zanetta Lamar, Dr. Tiffany Avery, they are both medical oncologists, and Dr. Karen Winkfield, a radiation oncologist. They host a popular podcast entitled The Three Black Docs. If you haven't checked them out, please take a listen. Today, they're going to share with you what you really need to know when you're first diagnosed and help you feel less overwhelmed and ready to take the next step. Living Beyond Breast Cancer is so grateful to these three amazing doctors for sharing their time with us and with all of you. If you would like more information on their podcast or breast cancer information, please visit our website at lbbc.org.
We know that cancer is a complex disease, and it's especially overwhelming for someone who may be newly diagnosed, especially with all of the terms and all of the subtypes, etc. It can be so challenging just trying to figure out how to navigate the healthcare system, especially as Black people here in America. My name is Dr. Karen Winkfield, and I'm here with Dr. Zanetta and Dr. Tiffany, and we are the Three Black Docs, and we want to welcome you today. We're going to talk about what you need to know as a Black individual, as a Black person who's been newly diagnosed with breast cancer, and share with you what some of the questions that you might want to bring to your doctors and how you can support yourselves as a cancer patient. So thank you again for joining us. Dr. Tiff, I'm going to start with you.
Yes.
This is very complex, right? All cancers are, but breast cancer in particular. Why don't you share a little bit about what's some information that someone with a newly diagnosed breast cancer should know?
Okay, so first things first, I want to thank Living Beyond Breast Cancer for doing this because you know how excited I am about education, right? Patient education and educating the community because this is so complex and there's so much information that comes at you at once, right? And so the more opportunities patients have to hear the information, the better. So for breast cancer, everything boils down to what type of breast cancer you have and what stage you were diagnosed at, okay? So let's take those two concepts separately. Stage. The first thing you're going to hear is stage, which could be anywhere from 1 to 4. It could be 0 if it's a non-invasive breast cancer as well, which is called DCIS or LCIS. But if you have an invasive breast cancer, the staging is going to be from 1 to 4. 1 is the earliest stage, 4 is the later stage. What it means is that stage 1, 2, and 3 are still local, meaning that the cancer has not spread from outside of the breast or outside of the lymph nodes associated with the breast. When you have stage 4, it means that the cancer has spread from beyond the breast and the lymph nodes associated to the breast to other parts of the body. And so your stage is critical because it will tell or it will determine how your treatment plan goes. Okay, so from stage 1 to 3, we talk about being curable. And with stage 4, we talk about treatments that will keep the cancer controlled.
So I'm going to go to Dr. Zanetta. So Dr. Z, I want you to talk about some of the tests that we use to even determine whether or not someone has breast cancer and what their stage might be. Why don't you go into that for us?
Sure, and I'm so excited to be here. Thank you so much, Living Beyond Breast Cancer. We are so happy to speak to you and to educate you about breast cancer. So, I see breast cancer patients all the time. And, when I first walk into a room, it's really just, I want you to know that there are people who care about you and we are here to take care of you. Okay, so feeling comfortable with your treatment team is really important. And so like like Tiffany said, there will be a lot of people that you come in contact with. Sometimes you may see a surgeon first. Sometimes you may see, a chemotherapy doctor like me first. And so really what happens, I know a lot of people, you've experienced breast cancer or you've known someone who's had breast cancer. And so, Dr. Tiffany was talking about the different stages, but there are lots of tests that we do, and some of those tests depend on the stage of disease. So most women would have had some sort of imaging of their breast. And what I mean by imaging, a mammogram. In some cases, we do an MRI to evaluate the breast tissue further. Depending on the stage, we may do a CT scan. And, this is something that's unusual because I see a lot of people and they say, hey, when am I going to get a CT scan of the entire body? If you have an early stage breast cancer, we know that the likelihood of it spreading beyond your breast is pretty low. So you may not get a full CT scan of your body. And that's really an important point that I would want you to know about. And so, we do mammograms, we may or may not do MRIs. And so there will always be some sort of a surgery in the form of a biopsy. But there are different types of surgeries that we do for breast cancer. So there is something called a lumpectomy, which takes, the breast tumor, and that's a smaller surgery. And so there are different criteria that we use to determine who may or may not get, that smaller surgery. There is also something called a mastectomy, and that's when the entire breast tissue is removed. And when we think about breast cancer and what to ask early on, one of the most important questions to ask is, what kind of surgery, if I'm a candidate for surgery, what kind of surgery will we have?
Yeah, yeah.
You know?
What's interesting is that, oftentimes people get confused. Cancer can happen in any organ in the body. And the
Absolutely.
breast has two specific types of tissue that is important. And I know Dr. Tiffany had mentioned DCIS. Remember, the breast is made of these organs called lobules, and that's where if a woman is breastfeeding, for instance, that's where the milk is made, is the lobules.
Mm-hmm.
And the duct tissue is literally the conduit where the milk goes to the nipple. And so that's the duct. And either one of those tissues are specific to the breast and can become a cancer. And so ductal carcinoma in situ just means that there's a tumor that's formed inside the lining of the duct. And similarly, lobular carcinoma in situ, LCIS, is where there's tumor that's sitting inside of that lobule. Hasn't come out, hasn't broken out yet. So remember, when Dr. Zanetta is talking about the ability just to go in and do a small surgery, a lot of it's based on, has it spread outside of the organ? Is it an in situ? Is it a
Right.
ductal carcinoma in situ? Or is it invasive, meaning it's had the opportunity to break outside of the duct or lobule? And if it has, then that may mean that you might need to get a sentinel node biopsy. Dr. Tiff, why don't you share a little bit about sentinel nodes?
Yeah, so the sentinel node is the first node that drains from the breast, right? So lymph nodes drain parts of the body. And when a surgeon wants to look at whether or not there's cancer in the sentinel node, what it means is that they find the first lymph node that drains from the breast to see if there's cancer there. And that helps with cancer staging. That was actually an advance, a huge advance in surgery, because before the sentinel node biopsy, women and men with breast cancer were getting a lot more lymph nodes removed, whereas which can cause trouble down the line with swelling, lymphedema in the arm. Now by
Lymphedema,
yeah,
meaning the
swelling of
swelling.
the
Yeah.
arm, right? And so now with being able to sample, just that first lymph node draining from the breast and being able to stage a cancer that way, that has saved a lot in terms of complications.
Yeah.
I think what is interesting and important here to mention, though, is, we're talking about a lot of different parts, pieces of treatment.
Right.
And so that is, a very basic thing to kind of wrap your mind around if you have a new diagnosis. And that is that there are different oncologists who do different parts of your treatment. And so depending on your stage, the parts of your treatment will consist of surgery, so you'll see a surgical oncologist for about surgery, then a medical oncologist to talk about chemotherapy possibly, or endocrine therapies, pills that you might take depending on what type of breast cancer you have. And then you will also see a radiation oncologist like Dr. Karen to talk about whether radiation treatment is indicated. And so I think part of the whirlwind, right, when you're first diagnosed, besides just hearing the C word and getting, past that initial shock, is that once you get that diagnosis, things start rolling. All of a sudden, you've got 3 appointments. You got to be here, there, and everywhere. And it's like, who are all these people, right? But those are the 3. It's your surgeon, your med-onc person for chemo and endocrine therapy,
Medical
and then your radiation
yeah.
doc, right? And also a plastic surgeon in some instances if you're talking about reconstruction.
Right. So you talked a little bit about the different types of treatment. You mentioned endocrine therapy, and I think that brings up an important point, right?
Yes.
When the tissue is taken out, it gets looked at under the microscope. Remember, it's not just those 3 doctors. There's a whole team around you, right? When you get a diagnosis, there's a pathologist, which is a doctor that looks at the tissue underneath the microscope. We already mentioned that there may be a mammogram or MRIs or other screens. That's a radiologist who reads those images. But when that pathologist looks at that underneath the microscope, they're looking for a couple of things. Which tissue did it come from in the breast? What's the grade, meaning how aggressive does that tissue look? And that gets scored on a 1 to 3 scale. So it could be a grade 1, which means, hey, it looks quite normal, looks very close to what a normal breast tissue looks like, versus grade 3, where it looks very aggressive. And that can actually help to dictate what some of the treatment might be as well. But we're also looking to see if there are special markers or proteins on the outside of the cell. So Dr. Zanetta, talk about those proteins and talk about specifically for Black women what some of the challenges may be around those markers.
Exactly. So anytime we look at a pathology report, we always want to know whether or not those markers are estrogen positive. There's another, we call that ER. We also have progesterone positive, and there's also something called HER2 new. Why that's so important is because as a medical oncologist, that determines what tests I do. It determines, what treatments I do. It determines whether or not you get a pill. The thing that's so specific in Black women is that often in Black women, none of those markers may be present. And so treatment options may vary significantly because of that. And so that's something that we call triple negative breast cancer. And so when you are diagnosed with breast cancer, I recommend all of my patients to get a copy of their pathology report. You should know what is being said about you. And so on that pathology report, it will say whether or not, it may say something like invasive ductal carcinoma. It may say ER positive and tell you how positive the ER is. It will tell you how positive the PR is, or whether or not, the HER2 is positive. And triple negative, you won't see any of that. And so that's really one of the challenges that we have as Black women in treating breast cancer, because it limits some of our treatment options.
Yes.
Okay,
so,
can I? Oh, sorry.
Yeah, go ahead and jump in.
I was going to pause for the cause because I think we have covered the top 3 things that I think everyone should know. And so if you get nothing else, get this.
Right. Let's do a quick summary. Let's do a quick summary again.
Because we just covered it real quick. But
Yes.
I mean, these are like the points that I think everyone should know. And that is know your stage, right? Know what type of breast cancer you have by receptor status, ER, PR, and HER2.
Right.
And
versus
then
triple negative.
Right. And the third thing is I see a lot of confusion between grade and stage. So I'm so glad you brought that up, Karen. And that is that your stage is from 1 to 4 or even 0 if it's not invasive, right? Your
Or
grade,
DCIS.
right? Your grade is what is on the pathology report about how your tumor looks under the microscope.
Right.
So I think if you get those three things,
Mm-hmm.
you're already
You're ahead of the game.
ahead of the game.
Let's talk, though, a little bit about why this is important. So
Yes.
anytime there's a breast cancer diagnosis, a clinician is going to say, what are the tools that we have in our toolbox
Yes.
to treat this? And
Yes.
so all of this information is important. The ERPR, so estrogen and progesterone, those normal hormones that women have, can sometimes drive tumors, right? And so it's important to know if those are present, because we have special medicines, usually by pill, that can be taken that can help reduce the levels of estrogen that are in our body, or to even prevent those cancers from seeing, if you will, the estrogen. Now, HER2, I tell you, there's a medicine called trastuzumab, which has revolutionized the treatment of HER2 positive tumors. Which one of y'all want to take that, my medical oncology colleague?
Well, I'll take, because, you know, I have given whole hour in long talks just about HER2 positive breast cancer, or just about triple negative. But this is what I'll say broadly and generally. So in terms of the different subtypes, right? The ERPR positive subtype is the most common when you look, you know, just across the board across the US. That's about 60% of breast cancer diagnosis, right? Which is ERPR positive. Now, besides treatment options, it also tells us about how the cancer will behave in terms of aggressiveness, in terms of chances of recurrence, or where the cancer may recur, okay? And so the ERPR positive breast cancers tend to be the least aggressive and the most common across the US in general. The issue is that, you know, when we start to look at Black women and we start to look at the more aggressive subtypes of breast cancer, the triple negative, meaning that you don't have any of those three markers, ER is negative, PR is negative, HER2 is negative, or the HER2 positive breast cancers, those two subtypes tend to behave more aggressively, and African American women, Black women, have higher rates of triple negative breast cancer when compared to other groups. Okay, so that's important because it's already a more aggressive breast cancer. Now, to talk about strides that are made with cancer treatments, right? So you mentioned trastuzumab and other drugs like it, which are targeted to HER2. That means if you think about chemotherapy, chemotherapy is going to hit every target. Tumor cells that are dividing in your body, but regular cells that are dividing within your body, right? So that's where some of the side effects come from, because, you know,
I think that's an important point. Real quick. So chemotherapy kills rapidly dividing cells. And that's one reason why with chemotherapy, you lose your hair, because your hair follicles are considered rapidly dividing.
Yes, or you get nauseous or you get diarrhea because the GI
it's impacting.
Right. Now,
back to the HER2, which represents about 25%.
It's a targeted therapy, which means that it will seek out, if you will, the cancer cells and leave normal, rapidly dividing cells alone, right? And so you don't get the same level of side effects as you do with like just kind of regular chemotherapy. Now, the issue with this is triple negative breast cancer, until very recently, we didn't have any targeted therapies. And that is an area that is rapidly evolving right now. The latest stride, if you will, in triple negative has been immunotherapy in the metastatic setting. But this goes to the important piece of clinical trials, right? Because the thing about triple negative breast cancer, A, Black women get it more. B, is more aggressive. C, less treatment options, because those targets have yet to be identified, and the targets that we have in triple negative breast cancer that have been identified are in clinical trial. So if you get a triple negative diagnosis, you want to ask about possible clinical trial options, and that is why, and I'm going to be quiet. Go ahead.
So let me just back up too, because I think it's really important, again, we're all talking about treatment, et cetera, but it's really important to know that not everyone with breast cancer will need chemotherapy.
Correct.
That is an important point.
There are some tests that we can do. So Dr. Z, talk about some of the tests that we do to differentiate who needs chemotherapy and who doesn't?
Sure. So in our oncology lifetime, there have been these genetic tests that we will send on the actual tumor specimen, and it will identify several different genes to see your risk of having an aggressive breast cancer in 10 years. How long will you live? A lot of these tests are predictive also of how well you will do with chemotherapy. One of the more common tests that we do is something called Oncotype DX. And so this test has really, and there are others. There's PAM50, there's MammaPrint. And so depending on, where you are in the country, different people may use different things. There are advantages and disadvantages for both. The most important thing that this test does, it saves us from giving chemotherapy to people who do not need it. And so that is so important, because I actually remember a day when we used to kind of guesstimate. We would sit and say, the risk is about this much. And so now we have objective data that will say, you know what? The chance of you being alive in 5 or 10 years is like 95%. So we don't recommend that you have chemotherapy. So honestly, more of my conversations now are not about chemotherapy. Because of improvement in screening, we're seeing earlier stage breast cancers.
Yes.
And I can say, hey, you know what? You might just need a pill, or you may just need nothing at all.
And this is why it's so important. First of all, this is why it's important not to compare your cancer to someone else's, right?
Yes.
You never know.
Everybody's journey is different.
Right? And
Say it again for the people in the back. Karen.
Right?
Say it again. Say it again.
Everyone's cancer is different, y'all. So stop comparing yourself one to the next.
Yes.
Okay?
Right.
And that's why it's really important to ask the questions, asking about what your stage is, asking about your marker status, asking about your grade, asking about your genetic test and if you've had it done. And if you're young women, because we know breast cancer affects young women, young Black women the most, right?
Yes.
So triple negative breast cancer in Black women happens in young Black women. And so any woman that's under age 45 who's diagnosed with breast cancer, they need to be checked to make sure, at least to have a conversation with a geneticist, right? Or somebody who's going to say, is there a possibility that you might be carrying a known marker, in your family, right? Or if you have a mother or a sister, or, that has breast cancer, perhaps it may mean, we might need to check, right? So these are important questions to ask, and because it's really important, not only for your treatment, but also, again, so you don't know, your girlfriend down the street may have breast cancer too, but it may not be the same exact thing that you have. And so treatments will vary.
Can we talk about this for a minute? Two things. I hope I don't forget my points. Okay, one, genetic testing. If you have triple negative breast cancer, 60 or younger. So if you have triple negative breast cancer, because of the association between triple negative breast cancer and genetics in breast cancer, anyone up to the age of 60, so 60 or younger, should be getting a referral to a geneticist.
And that's BRCA1. You may have heard that, the BRCA1 or BRCA1 gene is really the one that's most closely associated with triple negative breast cancer in Black women. Okay?
Yes, BRCA1. Yes, correct. Now, the second point I wanted to make, when you were saying, try not to compare yourself to others. Also, try not to compare yourself to others when it comes to stories about how people tolerated treatments, okay? Because here's the thing. Your treatment plan is individual and specific to what you need, okay? And so a lot of times, we will see patients who have already heard that this person had a terrible time with chemo or that person had a terrible time. And it's like, you don't know if they're getting the same treatments. You don't know if they had underlying conditions that made stuff worse. You don't know if their doctor was doing everything they could to optimize other ways to get through those side effects. So please, if you have heard stuff from other people, about, well, this was horrible and that was bad. Just keep an open mind because it's specific to you.
Yes.
Okay.
Now, you said something that reminds me of Dr. Z, because she is the communication guru here. And so I'm going to pass it off to you. I do want to talk about radiation and when radiation therapy is indicated, but Dr. Z, go ahead and follow up on this line of thinking.
Right. So one of the things that's really important to communicate with your doctor is how you are feeling during treatment. I encourage all of my patients to write it down. If you say, you know what, I'm having trouble. I picked up a cold drink and my hands were tingly. Write it down. I want to know about it. I want to know about it because I can't help what I don't know. And sometimes it's hard. I may not be able to pull out the information. And so your doctor really wants you. If someone's giving you chemotherapy as a medical oncologist, we want more than anything for you to do well with it, to be able to tolerate treatment. And one of the other things that I want to bring up, and I know Dr. Karen wants to get to radiation, one of the things that happens, especially in a lot of my minority patients, particularly my minority women patients, inevitably, women are often the bedrock of the family. You are taking care of every single soul in your home. You may be the primary breadwinner, right? So you may not have time or money for a diagnosis of cancer. There's never a perfect time for this. And so one of the things that I think is really important is to have your community support you during this time. You need that support. You need people to carry you during this time. And don't be afraid to ask for help. Don't be afraid to ask from your healthcare providers, from your nurses, from your family, from your church or other community organizations for financial help. Okay, because in all of our offices, we have people who are dedicated to helping with the financial burden of chemotherapy. And we don't know if you don't ask. So I heard this one stat that I was actually surprised about, that in the first 6 months of a breast cancer diagnosis, there's actually been found that partners have more emotional stress than the patients themselves.
Oh, wow.
Isn't that interesting?
That is interesting.
That the partners are actually more emotionally stressed. And so, people who are in your life, don't push them away.
Yeah.
Because they're a part of this journey too. So Dr. Karen was going to talk about radiation.
Go ahead, Tiff. It looks, did you have something you wanted to add?
Just one quick thing. Then you can talk about radiation.
Thank you.
With what Zanetta was saying, also think about someone to bring to you with you to your appointments.
Yes.
To be a second set of ears and to write notes.
To write. Because patients only remember about 10% of what's said in the appointment.
And guess what? We know that. And we know that you're already you don't want to be in a cancer center. Your mind is spinning with a million things. So we know that most of what we say, you might not get. So, and we know that and we expect it. So if you have someone who is there as your pair of ears and taking notes, that is great.
And I will say, in the era of COVID, a lot of times, in my clinic, actually, we're not letting visitors in, but we have them on the phone, have them on FaceTime. I mean, whatever we need to do for someone else to be a part of the appointment. I mean, there shouldn't be an oncologist in the world who isn't able to accommodate that. Dr. Karen.
Well, I do want to kind of just talk a little bit about this too, because particularly for breast cancer patients, you mentioned, there's this superwoman, and we can do it. And it's really important, right? And yes, men get breast cancer too, but this is really a disease of women primarily. And oftentimes people suffer in silence, right? There are some of our therapies, maybe they won't lose their hair, right? And so nobody's necessarily looking at their breast. And so there are women, particularly Black women, who suffer in silence because they're afraid to tell their community or their family, or they don't want to. They don't want people in their business. But they also have to continue to work, or they continue to have to take care of their family. And so it's one of these things that's just really important to find the Bible talks about those 5 smooth stones, right? Who are your people that are in your pocket? Who are your people that you can rely on, that you can can trust, that you know are not going to spread your business. I mean, if you don't want to share, then that's up to you. Some people want to tell the world, and that's fine too. You have to find what works for you and find out, though, how you can actually utilize your community, whether that be your family, your friends, or your church family, because it's not good to suffer in silence.
No.
There's a lot of mental anguish, and that stress can actually impact your outcomes.
It absolutely.
Yes.
Absolutely.
But just remember that, what we're saying is really to say, we want you, if you're going through this journey and you're newly diagnosed with breast cancer, we want you to have the best outcomes. That's why we're doing all those tests, to say what are the tools that we need to use. But then know that your team that's around you, your doctors, the nurses, the therapists, we're here for you. And please speak up if you are having mental anguish. If you say, I don't have a community, because there are probably some who don't, who really are going through this journey alone. Let us help you find a community that can help you go through this journey. Tiffany, you have something you want to say before?
Very well said, Dr. Karen. And now I'm going to put on my Dr. Karen moderator voice. Excuse me. So, Dr. Karen, could you please tell us?
Did you see she did the neck too?
Oh, did she? Oh,
yeah, she did the neck. She did the neck.
Could you please elaborate on the use of radiation therapy for a newly diagnosed breast cancer patient?
Well, absolutely, I will. Thank you very much.
Thank you.
So I am going to just say radiation therapy, first of all, is just the use of x-rays to treat cancer, okay? People have x-rays, they go, have a cough, they go to the emergency room, they get a chest x-ray. Does it hurt? No. Does it sting? No. Does it burn? No. So radiation therapy is the same principle. It's the same type of energy. We just kind of turn it up just a hair. And what that does is it actually causes damage inside each cell in your body. Yes, it affects normal tissue too, but it actually causes damage within the tumor cells that may still be present, and it prevents them from making copies of themselves. Now, people might say, well, what is the purpose of radiation? I've already had surgery, right? Surgery took the tumor out. So why do I need radiation? Well, remember we talked about those clinical trials, right? We talked about research and the importance of it. Back in the day, women who had breast cancer oftentimes would have these very morbid surgeries where they would do a mastectomy and take off muscle and take off all sorts of stuff.
Disfiguring.
Very disfiguring. Lymphedema, swollen arms.
Right.
And over time, people were like, is this necessary? And eventually what happened is, instead of doing all of that surgery, instead of taking off all the tissue, we started using radiation therapy as an adjunct to the surgery. So is there a way to just take out the tumor and then give radiation therapy to help sterilize the rest of the tissue, if you will? And so what we found out through that research is that women who have lumpectomy followed by radiation therapy have the same outcomes as women who go through mastectomy. So that's an important thing to note, that if you have a lumpectomy, the standard of care means that you also need to have radiation therapy. For most women, there are some women, if they're over age 70 and have very small tumors that have estrogen and progesterone receptors, you might not need radiation therapy. But for most women, particularly young women, if you have a lumpectomy because you have an invasive cancer or you have a ductal carcinoma in situ that's over 5 millimeters, which is wee tiny, if you have a tumor and you just get lumpectomy, radiation therapy is part of your treatment. And that's important because I've had patients say, oh, I just do what the doctor said and the surgeon told me I won't need radiation or I won't need chemotherapy. And I'm like, excuse you?
Wait.
Really important. And I understand. Please, I do not misunderstand me. It's really important to trust your doctor, but that means you need to have conversations with your doctor. So that's why we're trying to provide some tools to talk about. And it's really important to have conversations up front before you make a decision about surgery, because I've had women who say, oh, I was told if I have a mastectomy, I won't need radiation. Well, that's not true either. What happens if you have a very large tumor? Or what happens if you have lymph nodes involved? The radiation therapy doesn't just take care of breast tissue, it takes care of the entire region, and it's really important. Now, here's one of the things to keep in mind. While radiation therapy doesn't hurt, sting, or burn when it goes in, the course of radiation therapy can be pretty long. It can be anywhere from 3.5 weeks to 6 weeks, depending on whether you just need your breast treated or whether you need your lymph nodes treated. Again, it helps take care of regional areas that surgery wouldn't be safe to take care of. No surgeon is going to take care of these nodes up here above your clavicle, but they will take care of nodes in your armpit, right? But these nodes up here, we can give radiation therapy very safely and without having a lot of morbidity or toxicity, okay?
And Dr. Karen, can you expound on how radiation has changed? Because a lot of women will say, oh no, they're going to burn me up.
Well, it's changed dramatically. Thank you for bringing that up. So, if we were talking 30 years ago, first of all, we didn't even use CT scans. We talk about these CT scans, which are important for looking at and staging some cancers. We actually use CT scans now to guide our therapy, which means we can better target where the radiation therapy goes. Back in the day, we didn't do that. And so oftentimes women were getting treatment to large areas of their body that they didn't need to. Every woman's body is different. And so the beautiful thing about getting a CT-based plan for radiation therapy means I can actually target the radiation exactly in the area it needs to be, but spare important normal tissue like the lung, which is underneath the chest wall, and also the heart, which is on the left side of the body. And so we really want to be able to do that with radiation. We also are using machines that have much better targeting capacity. They're not kind of treating with low dose, which means women with their skin would get really ripped up and it was bad. It would definitely get burned. And so now we're using much higher energy, which allows us to treat in the area with causing less damage. Now, I'd be lying to you if I told you there would not be any side effects. And let me tell you, radiation therapy impacts Black women differently. And this is an area that I'm researching actively. So for my white patients, oftentimes they'll come for radiation therapy. They'll get treatment the first couple of weeks, no changes. Eventually, I'll start to see a little pink on their skin. Well, for my Black patients, that's not the case. My Black patients, what usually happens is they're doing fine. And then toward the end of treatment, all of a sudden, one day, they all of a sudden, boom, their skin turns black.
Yeah.
It's really,
Very
really
dark.
And that discoloration can last for a long time.
Mm-hmm.
And the challenge is that a lot of my colleagues who may not be Black might not even pay attention to that and will keep treating or won't talk about the importance of skin care when that skin turns dark like that. And
Can you touch on that a little bit? Because a lot of people don't talk about the skincare and kind of what should be done.
It's so important. So I actually, from day one, when my patients start treatment, I encourage every woman who comes and every man who has radiation therapy to moisturize their skin.
Yes.
Any kind of lotion, I don't care what it is. You don't have to get anything fancy or expensive. You go ahead and you get the CVS brand, whatever, as long as it's non-fragrant or hypoallergenic, or you can use whatever you have at home. I don't care if you use baby oil or something, just moisturize your skin a couple of times a day. Number one, radiation therapy can dry your skin out.
And so does chemotherapy. Mm-hmm. Chemotherapy really dries your skin out. So often we'll do, chemotherapy first. So you're kind of going in with dry skin, depending on how you're being treated. So these are good points.
So the skincare is important. And I do tell people not just moisturizing with lotions, et cetera, but moisturizing from the inside. So drinking water. Water, believe it or not, is really important during the course of chemotherapy even, making sure you're flushing out the toxins out of your body. And so it does help to hydrate the skin when you're drinking the water as well. And so I do think that it's important, even if you talk to the radiation oncologist and you're having meetings with them and they're talking to you about the side effects of radiation, they talk about skin, say, well, what do you recommend for skincare? That's an easy question to ask. And there might be some slight nuances, some slight differences in terms of what someone might recommend, but really important. And always, every week, again, this might be 3.5 weeks or 6.5 weeks of therapy, depending on what your specific cancer is and what needs to be treated. Every week, you should be seeing your radiation doctor, every week, to check in so that they can look at your skin and make sure that everything's going okay. And that's a great time to ask questions as well. Anything else?
Oh, that was Radiation 101, Dr. Wingfield.
Yes, and I feel like you guys don't get enough time to really talk to people about radiation.
Right.
That's my opinion.
I agree. I thought that was good. And so sometimes we will use a different term for lumpectomy and radiation. You may hear the term breast conserving therapy. Mm-hmm. Okay, right. So that means the same thing as a smaller surgery plus the radiation.
And that's important to know because, again, the majority of women, if you have the option, most women, about 70% of women want to preserve their breast. Mm-hmm. And so you can have breast conserving surgery, which is the lumpectomy, But again, if you have that, important to include the radiation, and then it becomes breast conserving therapy. And so the options oftentimes may be presented. Do you want breast conserving therapy, or are you interested in mastectomy? And the other thing that Black women oftentimes don't get, and this is going to be a little bit off, if we're talking about mastectomy now, oftentimes Black women aren't always encouraged to think about reconstruction. And I bring that up because let me tell you something. I have seen women who have had mastectomies, and I couldn't tell that they had a mastectomy. That's how good the surgery was, okay? They have all kinds of mastectomies. They have skin-sparing mastectomies. They have nipple-sparing mastectomies. And so it's really important, again, before you have surgery, to talk about what your options are. And if you're going to do breast-conserving therapy, lumpectomy with radiation, that's fine. But if you're electing to have a mastectomy, please ask about whether or not you're a candidate for reconstruction. And that will mean you having an appointment with yet another doctor, a plastic surgeon. But it's so important. And please take the time to do that. If you get a diagnosis of breast cancer, there are very few breast cancers where you have to make a decision that day. Very few, right?
Right.
I mean, what? Maybe inflammatory?
Inflammatory. Now, inflammatory, you need to see us yesterday. But outside of that, I mean, really, you should have time.
Exactly. So you have time, but not a whole lot of time. Don't dilly-dally.
Now, not 6 months. We're talking a few weeks.
You're talking a few weeks. Exactly.
Okay, not 6 months.
And just as a note, as you're seeing all these different doctors, the sequence of your treatment, whether you get chemotherapy first, then surgery, or surgery first, then chemotherapy, those are all also based on your particular situation. So, you know, you might hear of a friend that got surgery first, then chemo. You might get a recommendation to get chemotherapy first to shrink the tumor and then get surgery. And so that's an option as well. You know, so once again, just being aware that there's so many different ways to treat based on what is going on with you as an individual.
And when we talk about terms, if you get chemotherapy before surgery, that's called neoadjuvant. So you may hear, we throw out these terms all the time because we really like to sound smart. We paid a lot of money for school. So we need to sound smart.
Wow.
So instead of saying chemotherapy before surgery, we'll say, you know what, I recommend that you have neoadjuvant therapy. Or if you have chemotherapy after surgery, we call that adjuvant. Adjuvant therapy. So just a little term to be aware of.
Yeah. And just know that from a radiation perspective, if you don't need chemotherapy, again, we've already established not everyone who has breast cancer will need chemotherapy.
Right.
If you have a lumpectomy, if you have breast conserving surgery and will need radiation, the radiation therapy is done after surgery. And usually I like to wait anywhere from 6 to 8 weeks after surgery to begin radiation. Your body needs to heal. Right? You need to heal from the surgery. The surgeon goes in and takes that tumor out with a little rim of normal tissue around it, but they don't sew that tissue together. They leave it open. And there's fluid that can collect, and it takes time for your body to heal over time. That's called a seroma. So
repeat that word.
Seroma, S-E-R-O-M-A.
Yes.
And some of you may have had a lumpectomy and felt like, oh, it feels almost like there's a balloon or something that's in there. That's the fluid collection. And over time, your body should get rid of that. But occasionally I have seen where patients, it's not going away, and you might need to go back and see your surgeon, and they can stick a little needle in there and take some of that fluid out. You know, it's usually right there in the room. You don't have to go to the operating room or anything like that. But you do know it's okay to call your surgeon. If you're having an issue or you're having some pain that lasts for more than several weeks, call your surgeon.
Particularly if it's associated with a fever.
Yes, definitely if it's associated with a fever, yes.
Mm-hmm.
So, you know, we probably need to move to what resources patients can have because, you know, we've talked a lot about, you know, the types of cancer that they are, the testing that we can do to kind of figure out what the stage, the different types of treatments. But this is a tough journey, right? This can be a challenge, and we've already talked about trying to develop our support systems. But what other supports are there for patients? And Dr. Zimmerman, tell us about what you do for your breast cancer patients down there in Florida.
Sure. So I like to read books, and I like for my patients to have books. Actually, one of my favorite books for patients, I don't know if I'm able to do this, but I'm going to do it anyway. But it's called, can you see this? I'm going to take the hospital name, but it's the Breast Cancer Treatment Handbook. and it's by a lady called Julie Neese, Kneece. And this is actually, I think it's a good book to have. It goes through basically every single term. It has very good questions to ask your surgeon, to ask the plastic surgeon, to ask the radiation doctor, to ask the chemotherapy doctor. There are pull-out worksheets for you as well. And I actually looked it up on Amazon last night, and it was $5.
Wow.
So this is well worth your time. And believe it or not, I keep it at home because I like to see what my patients are reading, you know, and I like to have it too. Yeah. So it's so, you know, I think that's good to have. You want to have a nice educational resource. And really, Living Beyond Breast Cancer is a wonderful, wonderful resource. They have hotlines. They have people that you can talk to. And the fact that you are plugged into this seminar says so much that, that you are already plugged into a network that is invested in you. One of the things that, I mean, I saw everything from, you know, vaginal health to supportive care to.
Wait, you mean like sexual health is important with cancer? Sexual health?
Oh yeah,
let's
that's another hour talk. I don't think we have another hour.
No, we don't.
You know what? But we have 2 minutes.
LTC, yes, but that's good. But you know, that's great. And the tip, what other? Because I know, you know, you've also been able to provide resourcing for your patients. So talk a little bit about,
you know what I would say first is like start local. Ask at your hospital if there are patient navigators, right? Because the difference that a patient navigator makes in terms of getting you through all this stuff, I mean, we have research to show the impact of a patient navigator. So, you know, the first thing is like,
out of my office, I'm just saying.
Right, yeah, out of the office of the illustrious Dr. Winkfield. But no, really, so patient navigators are people who are, you know, who work at the hospital or at the cancer center where you're being seen, who help you navigate literally all this stuff that we are saying, right? They will help you to understand who all these appointments are with, you know, why you're going to see all these different doctors, putting you in contact with the social workers, you know, the financial counselors at your institution. Most cancer centers will have like a patient education center or something on the grounds, you know, and in my experience, it's usually like the place you can catch a quiet moment if you need it because no one's ever in there. And it always strikes me because usually there are all of these resources right there at the cancer center, at the hospital, that patients just probably don't know is there or taking advantage of.
And sometimes in the community, you know, the clinics may be smaller. And so, you know, sometimes, you know, the surgeons may be in a different place than the radiation doctors, may be in a different place than the medical oncologist. And so usually there are still local resources that may not, you know, be within one space.
Yes, but Dr. Z, your point is well taken.
Yeah.
So some of the smaller, we know that most of cancer care happens in the community, like 80%, and not at the big cancer centers where you can have that. So I do want to point out, in addition to Living Beyond Breast Cancer, we just have a few minutes left. I just want to talk about the Sisters Network.
Oh, I was going to talk about that next.
Work for African-American women.
Yes.
So check them out. There's all sorts of things. If you are thinking about a clinical trial, please look up the Lazarus Cancer Foundation because occasionally they can provide support, transportation support, housing support. If the clinical trial is near you, but you're struggling with paying for gas, going back and forth, et cetera, that's another resource because financially this can be tough, right? And so that's what's important. So make sure you're looking up. Cancer.It is another resource that you can check out. That has a lot of information, that's trusted information that you could look at to make sure that you understand your diagnosis. And then one final one that may help with resourcing in terms of finances, et cetera, is Cancer Services. And it's Cancer Services Online. So please make sure that you think about that. Please stay away from Google Doc. Just don't Google anything. We want you to go to trusted sources, and definitely make sure you're talking to your care team. They can provide you some information as well. So, Dr. Z, any last minute, one or two phrase, make it quick. We got 2 seconds left.
One or two. You have breast cancer. Breast cancer does not have you.
Yes. Okay. I love that. Dr. T?
Hmm. Well, I'm always about community. So, I really like the idea of making sure your support is in place,
Mhm.
who's coming with you to be your set of ears and taking notes with you at your appointments, helping you keep straight, and who can you go just to talk to and confide in as you go through
Mhm.
this.
Love that. And you know what? Cancer is not a death sentence. Okay?
Right.
Breast cancer is not a death sentence. And you will get through this. My hope is that this information that we provided tonight, if you are just starting this journey or if you've been on this journey for a long time, hopefully you learned something today. We really appreciate you tuning in. And again, really want to thank Living Beyond Breast Cancer for doing the amazing work that you're doing and
Yeah.
putting on this forum. So thank you so much, and y'all have a good evening, okay?
And on behalf of Three Black Docs, please, listen to our podcast. We have a new podcast that drops every Tuesday.
Mhm.
So you can find us at Three Black Docs on Facebook, Instagram. And, our goal, the reason why we started this podcast is because we want to educate our community.
Yeah.
We want to end disparities in any way that we can. So
Hmm.
thanks for this opportunity, and we wish you the best of luck on your journey.
All right.